Hi, my name is Michelle Larned. I'm the Director of Clinical Services for the Southeast area for Vinfen. And today we're going to be talking about the definition of insanity. My panel here today is Judge Steve Leifman, Miami-Dade County Court Associate Administrative Judge, Chair of the 11th Judicial Circuit Mental Health Committee, and subject of the film. Hi, Judge.
Hi, how are you?
Good. Justin Volpe, Peer Specialist at the National Association of State Mental Health Program Directors, Board President at Miami Recovery Project, and another subject of the film. Hi, Justin.
Hey, how are you? Thank you.
Good. We also have Dr. David Hoffman, Massachusetts Department of Mental Health Metro Boston Area Medical Director. Welcome, David.
Hi.
And then we also have Patty Contente, LICSW, City of Somerville Police Department, Community Outreach and Recovery. Hi, Patty.
Michelle, thanks.
All right, so we're going to get started with questions for the panel. And this first question is going to be for Judge Leifman, and then we'll go over to Justin for more. Can you discuss the difference between mental health and drug courts and this program?
Sure. And again, thank you so much for moderating and hosting today, and we really are thrilled to be here. There's a significant difference between the populations, although they all are under the behavioral health umbrella. Some individuals have their underlying issue or illness may be substance use disorder, and others, the underlying issue may be a serious mental illness. Most mental health courts try to take people with serious mental illnesses, although the vast majority of individuals who come into the criminal justice system with a serious mental illness also have what we call a co-occurring disorder, so they have both a mental illness and substance use disorder. Our program is unique. It really isn't about a mental health court. It's kind of the least of what we do. One of the problems with mental health courts nationally is they're too small in scope. They generally only take about 1/10 of 1% of the population that actually needs it. And often the 1/10 of 1% that they take are not necessarily the best fit for these programs. They often take lower risk individuals that are probably going to be fine without us. What we do is we're a diversion system, and we have a large staff of about 25 people, of which Justin was for about 13 and a half years. And what we do is, we have a pre and post arrest diversion system. And that means that it includes both a very sophisticated CIT program where we have over 7,600 police officers trained in crisis intervention team policing. So we work on reducing the number of people coming into the criminal justice system. And then we have a post-arrest diversion system where we identify people at various stages in the system once they've been arrested to identify them, see if they qualify for our program. And if they do, then we divert them out into community-based treatment. And our courts help monitor those individuals. But for us, we generally take anybody charged with a misdemeanor, and we generally take all nonviolent felonies and some other possible slightly violent type charges. People don't appreciate always that, more than 98% of people with mental illnesses who are arrested are going to get out of jail relatively quickly. And so it's really important that if we're, that knowing people are going to get out, that we have two choices. We can release them with or without treatment. And we know that if we release individuals with treatment, they're going to do a lot better. And that's what we've seen happen here. And it's just been an incredible journey for all of us. And I think sometimes we get more out of it than the people that we're serving, because there's no greater gift than to watch people recover.
Great lead in to Justin. Justin, can you talk about that and what this looks like for you, particularly coming off of what he said about watching people recover?
Yeah, well, having worked in the program, it was 14 years, Steve. Don't cut me my last 6 months now. I did work. It wasn't much work, but right. I worked in the community with these individuals we served, and to kind of tie in your previous question is people with co-occurring disorders or with mental health and substance abuse. There was very few people that I worked with in the community that had just a mental health issue without any underlying use, but there was some. there was people like that I worked with, and we served. And to see people recover, to work in the community, I did this from basically a child. I was an adolescent. I was 23 years old when I came into the program, and I grew up, under the lead of Judge Leifman and great staff, and was taught how to serve the community and learned what was missing and trying to bridge those gaps. And there's a lot of things that need to be fixed, but seeing people and supporting people, whether they have substance abuse or mental health, it's more of a compassion issue, and being willing and able to serve the community and work together as a team. And that's what it was all about.
Thank you. Yes, I thank you so much for saying that. I think one of the things that we really like to talk about here at Vinfen is about recovery, and that people can, move on and get better. So the next question is going to be for Patty, and then David. Massachusetts has some jail diversion programs. Can you discuss what these programs in Massachusetts look like?
Yeah, sure. Thank you, Michelle. So in Massachusetts, it's a little bit different. We don't have a huge diversion system. So through the Department of Mental Health, we were funded initially in 2011. And it was based more in a community localized model. And so our jail diversion programs are oftentimes based in a police department. And then those police departments have relationships with their district court. And so whenever there's an individual, and I really appreciate Judge Leifman's comment around, many individuals who could benefit from diversion are getting more serious charges, more complex charges that the trial courts and district courts are not able to divert. So these community-based programs really allow for anyone is open to it. We started focusing on primarily clients who were involved with the Department of Mental Health, but quickly learned that there was such a broader population out there that could also were struggling with behavioral health. And so our model is we don't have a specific program or a system. However, we work, and one of the benefits of that is that we are able to individualize services much more. So when an individual comes in for diversion, we check with the police officer who is the arresting officer. If they're in agreement, which most times they are, then we meet with that individual and we come up with a treatment plan that's going to really focus primarily on skill development and support for treatment and recovery. And so we work with many times. What we find is individuals do have service providers. They do have a case manager. They do have a psychiatrist. They do have therapists, but they're not really utilizing them well. And so the diversion really, we have found, makes a significant difference in helping those individuals be more effective in utilizing their care, partnering with their providers. And it also allows to address those other social determinants of health, like housing and finances, employment, education. But it is challenging. When I watched the film, I was very jealous of the residential aspect and the housing, because it's hard to get stabilized if you don't have that kind of foundational structure. So that is a huge gap in Massachusetts.
David?
Well, I would echo Patty's last comment. I think that, stable housing is a major social determinant of health, and at least in Boston, with which I have the most experience, a lot of the folks in question are homeless, and we don't have the residential resources. And so if you divert someone and they don't have stable housing, we do have some outreach, but the challenges in terms of making sure that people follow up with treatment are that much greater. And, in terms of the sort of pre-arrest versus post-arrest, I think that's where we're most successful, crisis intervention training. I think a lot of police forces in Massachusetts now are trained, and what happens is people are not arrested in the first place. They're taken to emergency rooms. And there, the challenge is between our, commitment laws and the lack of housing. I mean, that creates a huge challenge, and I'm jealous of the system that you all have built. And I just wanted to thank Judge Leifman and Justin. I mean, you've done an incredible job. I think it's a great film, and the work that it represents is a great achievement.
I completely agree. The amount of people that you've helped really I think just makes us better altogether. So you all have introduced a little bit of one of the barriers, particularly in Massachusetts, which is housing. So this is to Patty and David again also. So what do you think would need to happen in order to have a model like this, and which key stakeholders would be important, particularly addressing the barrier of housing? David, do you want to go first?
Sure. Just send money. No, I mean, basically, one of the compelling statistics at the end of the film is about the fact that ultimately, in addition to helping people in a humane way toward recovery, that actually you save the state money in the long run, plus you improve public safety. And legislators that are looking at budgets, governors the same, they like to see those types of statistics. And I think, as you did in Miami, I mean, you really need to start small. I mean, even if you start with an 8-bed residential program, it can grow to 16 to 32 to 64, but you have to start somewhere. It has to be a dedicated program with the linkages to the courts. I think that's really what it would take. Another issue which is somewhat controversial, which in certain extreme cases is helpful, is having outpatient assisted treatment as an option, popularly known as outpatient commitment. And Massachusetts is one of the few states that does not have a statute to that extent. And the statute requires infrastructure to make it work. But I would invite Judge Leifman to talk a little bit about how that might work in the program in Miami.
You want me to jump in?
That was actually going to be one of the next questions, was like, what resources are required and how do we
I could jump in just before you get into that.
Sure, go for it, Patty.
I agree with David. I think starting small is important. I think also there's a lack of flexibility within large systems. So we have the state, and there's policies within the state, and then federal government, HUD, which kind of really finances a lot of the shelter programs and housing. And there's kind of always this kind of philosophy shift. Who are we serving? Who's the priority? Is it chronic long-term folks who have been unhoused, or is it more newly unhoused? And there are different challenges for those different populations. And I think one of the things that we've seen in small areas be successful, like the Miami program, but also I'm thinking of ROCA, which, not focused on housing, but very high-risk youth, is a combination of public and private funding, because it is costly and it is going to happen in communities. So how can we, kind of start to partner more traditionally outside of the box in terms of bringing in those private donors and investors and municipal governments, local government, as well as state and federal, to kind of have that collaboration to address these very large scale concerns. So I just want to kind of highlight that.
Thank you so much. So but I think you spoke exactly to what, Judge, maybe you can talk about what resources made this program possible in Miami, and what does it make for it to be possible in places like Massachusetts or anywhere else?
So thank you both, though, for your very thoughtful comments. We really do appreciate it. And we kind of joke that we're a 21-year overnight success, and it takes time. And we did start very, very small. We really didn't know what we were doing when we started. We just knew it was wrong to have all these people with serious mental illnesses in our criminal system. And we were allowing them to cycle through all these acute, deep-ended systems and doing nothing to stop it. And so, you know, originally we didn't even ask for any money, because what we did is we had a summit where I invited all of the traditional and non-traditional stakeholders to a 2-day meeting. And we literally mapped out the intersection between the criminal justice system and the community mental health system, and realized that we were embarrassingly dysfunctional. We were the sick people. We had designed a system perfectly to fail, and it failed perfectly. And it wasn't nefarious. You know, people just don't understand the issue very well, and everybody's so busy doing their own job. No one individual or institution is responsible for this population that just keeps cycling back and forth. And once we realized that we were the cause and that we could make structural changes, we started to get to work. And it was very small, but there were already existing resources we just didn't even know existed. And so what we did initially is we put together a written collaborative agreement, and we got these other systems that were already getting funding to agree to take our population. And after about 2 years of some really decent success, that's when we went to our county government, and we were able to get some dollars from them. And then we started applying for federal dollars through SAMHSA and through the Department of Justice. And we initially got a SAMHSA grant. But one of the reasons we got the SAMHSA grant is we were able to convince our county that they should sustain the grant once it ran out. And if you have sustainability in those grant applications, you get like a zillion extra points. And the county said, hey, if you can show us that you're going to actually, you know, save us some money and, you know, improve our public safety, then, you know, we'll back it up. And so they did. And we were able to get some really interesting studies. We have a university in Tampa that is able to tell the community who the highest utilizers of criminal justice and mental health services were. I think it's mentioned in the documentary, but you know, they narrowed it down to 97 people that had been arrested 2,200 times, spent 27,000 days in jail, 13,000 days at a psychiatric program, and cost $17 million, and we got nothing for it. And so we were able to significantly reduce our jail population, our arrest population. And that's what really got the county to continue to fund these kinds of programs. But, you know, we've been very good at getting state, local, and federal dollars and blending it. While we have a staff of 25, they're paid from all kinds of different entities, not, you know, some through the court, and some through other entities that are assigned to us. And so we've just been able to figure out how to make that work. But David had asked about our assisted outpatient treatment program as well. And before I get to that, I also wanted to mention, we have a dedicated tax in Miami-Dade County for homelessness. And they were part of our stakeholder meeting. And, you know, they agreed that they would, you know, make sure that we had resources available and housing available when people were coming into our program. And that helped significantly. But what we have found is over the years, as we got more sophisticated and we started to do more research, you know, these are mental illnesses, not a mental illness, and there's different levels of acuity. And so, you know, people are unique and they have different needs. And we just keep narrowing down different pockets of individuals that need different levels of services. And there is a small group that really do need the assisted outpatient treatment. They lack insight to their illness. We've tried everything. And we really try hard in our program to get people to voluntarily take treatment. And it works better. But there are some folks that have been too sick too long and have been on the street too long and psychotic too long and have abused drugs too long. They just can't get to where they need to get without a little help. And so what we did is we got our legislature, because similarly, even though it's on the books here, David, very few communities in Florida want to use it. And they use the excuse of resources. So we actually got our legislature to extend jurisdiction for assisted outpatient treatment, or I think you called it outpatient commitment, to the county court criminal division. And so what we actually do, and it's fascinating, we have our criminal judges that handle misdemeanors applying a civil law in criminal court. And so it's for that individual who's been homeless for decades, who really been very difficult to get treated. And we put them in the program, and it's a miracle. Usually within 2 weeks, they've come back. They're put on a long-term injectable medication. They have insight sometimes for the first time in 10, 20 years. And the judges in there are just moved like you can't believe, because people, you know, they have their humanity back. They are aware again. And then we do everything during that period to make sure that, you know, they get all the services they need to maintain their recovery. But look, there's no one piece that fixes this. You need kind of this beautiful mosaic of different approaches for different people, and figuring out who needs what, and then making sure that it is available. You know, someone, you know, my mentor once said to me, there's no such thing as a treatment-resistant person. There are only treatment-resistant programs. And it's our responsibility to develop the programs that meet the person's needs. We do it for cancer, we do it for heart disease. Why aren't we doing it for people with mental illnesses? And we need to stop blaming them for not succeeding when we don't offer them what they need. So it's, you know, it's been quite a wonderful challenge. And, you know, I don't want to take up much more time, but, you know, in a minute, I want to talk about this new facility that we're getting ready to open, because that's kind of the next step for us.
I want to add something that, and this is going off what you said, Judge, and to David, is that after the AOT expires, it takes a community collaboration and peers to work with that person, that individual, to make sure that they're still being served. Because after that civil order expires, you know, they still need support to make the right choices. And there's a lot of debate, a lot of advocates debate whether forced treatment is necessary. And I think it's a hot topic. I've seen it work, and I've seen where, as an advocate, you may not want to do that to somebody. And, you know, to see somebody have life in them again is a beautiful thing, though. And to see people willingly feel better of just medication change. And I'm a person with lived experience. I have a diagnosis. As you know from the film, I went through the program 15 years ago, and I was treatment resistant. Maybe you could say the programs were, but I didn't want it. And it helped change my life. So that's all I wanted to add.
You mentioned peers. I mean, one of the things that really impressed me about the program and the film is just the centrality of incredibly talented, hardworking peers. And I think that's a crucial aspect of your success, and being able to engage people and hold people accountable like you hold yourselves accountable. And I just think that was very impressive. And that's another part of the model that I think we need to grow more. We've done something with peers in Massachusetts, but there's a lot more that we could do.
Well, remember, as a peer in the criminal justice system, our job is not to hold them accountable. We let the court do that. Our job is to build that relationship, to grow trust. And remember, peer support is voluntary, which puts us in a strange position sometimes with somebody that's in treatment court or in the jail diversion program, even though the program is voluntary. But unfortunately, their other option is they could go back to jail. So it doesn't feel very voluntary. So to build that relationship as a peer and to build that trust is a long-term relationship, and it is not a hierarchy. It is, we walk this page together. I've been in your shoes, and listening and learning from the individual instead of just unloading on them. And, you know, because if not, you become what? Another probation officer, another case manager. And that's not what peers do. We're here to walk this walk with you and talk you through it.
You know, for us, it's very clear that peers are the secret sauce of our recipe. A third of our staff are people with lived experiences, maybe a little bit more. And
are you including yourself? No.
Wrong if it was. But seriously, you know, what we have found that we had not anticipated is that for so many individuals, by the time they penetrate the criminal justice system with a serious mental illness, they often have clinical depression on top of their serious mental illness. The system is just beating them down. And, you know, for them to finally end up in the criminal system usually takes a lot. And so what we're finding is what the peers do so brilliantly is it helps them reestablish a relationship. You know, I always joke that, you know, we're kind of civilians that don't really understand this sometimes. And we think, oh man, if they just take their medication, everything's going to be fine. But hey, if they have to go back and sleep under the same bridge taking their medication, nothing's really going to change. They need a life. People need to have hope. They need to have opportunity. They need to believe that they can have a life again. And what the peers do so wonderfully and brilliantly is help them reestablish a relationship that incentivizes them to want to get better. And we don't even push the medication that hard until that process has actually begun, because we've learned that we're just going to push them away at that point. And so even with our AOT, by the time we're asking for an assisted outpatient treatment assessment, we've tried all these other components and they just haven't worked. And I think if you do it on a graduated step like that, I think more people would be willing to go along with it and wouldn't see it as some kind of, you know, forced medication system, but it's, you know, really just another tool in the box for people that need it. And, you know, and I remind people, you know, God forbid you have a heart attack, we don't run to court and find out if we should repump your heart and give you medication if you're unconscious. I mean, we kind of, you know, have this weird attitude for people with mental illness, like there's something wrong to get people treated and help them get better. So we've come a long way, and I think it's working very well, and the peers are a critical part of it.
And, you know, it's better to have some sort of early intervention than a more serious crime is committed, because I've experienced that, unfortunately, that, you know, participants do fail. The system does fail, whether it's them or the system, and we see poor outcomes. And sometimes I'd wish somebody would get a harder charge so we could help them more and have more, you know, leverage on them. So the system's not great, and it is a step, and I agree with that.
I'd also emphasize what Justin was talking about too, that is that aftercare. So, you know, oftentimes the challenge with our diversions locally is that the courts want to close those cases. They want to close them in 3 months, you know, wrap it up. And I'm always advocating, can we keep it open for a year? Because change doesn't happen so quickly. This is, you know, kind of at that probable cause stage. So there's no charge been filed yet. But it's kind of, that's where our model of the community outreach program at the police department, we're very low bar access. We don't need to access insurance to engage with individuals. And we have had recovery coaches and peer supports. So having that multidisciplinary team on a very local level in the community where the person lives to be a resource ongoing, even after, if there is a program that ends, trying to build those connections and relationships is so significant, because life continues and with that challenges. So it's great to have that continuum.
You know, Michelle, also sometimes we don't do a good job, and we've gotten a lot better, is getting to some of the root causes. You know, most of the individuals who come into our program have really severe histories of trauma, and we could give people all the treatment they want, but if we don't address the trauma issues, it's really not going to get a whole lot better. And so we got pretty good at offering trauma services and trauma treatment. And I think it's made a significant difference and impact. Understanding that it exists so that we're more sensitive when we talk to individuals with histories of trauma, but then making sure that they get appropriate treatment to deal with it.
Can I cut in real quick, not to take up too much time from the questions, but I just want to definitely emphasize that part of the solution that's worked in Miami-Dade is training with the police and CIT, and we have over 7,600 police officers trained in crisis intervention team training to de-escalate people with serious mental health issues. We've seen injuries go down from consumers and police, and it's part of the big reason that our jail populations has plummeted, and that you know, the recovery is in the community. And we've seen an attitude shift of law enforcement change over the last 20 years to wanting to assist and help these individuals rather than arrest. So I just wanted to throw that in there.
Thanks, Justin. That was actually going to be one of the next things we were going to talk about, because I wasn't sure that everybody knew what CIT was or if they had attended the film festival last year. So Judge, I am going to let you talk about your vision for the program, but first we are going to introduce an audience question first. And so this question is for Patty. Patty, with forensic cases here in Massachusetts being diverted to psychiatric facilities to receive evaluation and treatment, it seems like these forensic cases are not being granted additional funding, but instead only decreasing the direct psychiatric admission beds at state facilities. This obviously leads to civil commitment cases being waitlisted, patients being in short-term hospital units. So can you speak to sort of what this looks like for people?
Yeah, it's really challenging. And so if someone is court involved and they're recognizing that there's a behavioral health, mental health component, they can be referred to an inpatient psych hospital for a competency assessment. And those assessments are 30 days. So it is a long-term. The kind of downside is, I mean, those hospitalizations really do allow for a period of stabilization for the individual. So that's really positive. However, it's long-term, and it only reports back whether the person is competent or not for, culpability of the charges. So it doesn't really, follow through with, here's some recommendations for treatment or anything. It really is limited. And as everyone knows, there are very limited state hospital beds. It's creating, kind of a crisis really in hospital emergency departments where people are boarding, meaning that they are on a gurney in a hallway in an ED, temporary space for weeks before a psychiatric bed opens. And so a lot of times people are being discharged even before they get to that psychiatric hospitalization. So it really is a crisis in terms of how are we managing our resources. The closure of the state hospitals and deinstitutionalization was a good movement, but we really didn't account for the housing needs for people and the different levels of kind of structure and containment that people sometimes need. So yeah, so it is a crisis, and it's, I don't know, it's because of the competency here, assessments or so, but it's just a huge deficit in resources for patients.
I'd like to follow up because, first of all, I agree there certainly are not enough inpatient beds to meet the needs in Massachusetts at this point. I think it's complicated. Why? I feel personally it goes back to the stigmatization of mental illness, the fact that psychiatric hospitals do not have the type of reimbursement from insurance companies, including Medicaid, that people with heart attacks and broken legs get. And therefore, the incentive to take challenging patients from emergency rooms is just not there. And that's a national problem. It certainly is something that needs to be addressed. In terms of the state hospital system in Massachusetts, we actually do more competency evaluations in the state hospitals than many states do, where they're often done in jail or in the community. And the vast majority of those people, it's good that they're in a hospital because they need hospital treatment. On a given day, we have about 670 beds, state hospital beds, and about 9% of them, maybe 8% of them, are used by these evaluation patients. The problem is just, and those patients usually move on to another level of care. And it's often a time to engage people and start them off in treatment. I don't think that's really the reason that the system is jammed up. I think most of these people need to be in a hospital. What I feel is unfortunate is that you shouldn't have to be arrested to get into a state hospital easily. And that's where, or any hospital. And I think that's the dilemma. If a policeman works hard to avoid arresting someone, takes them to an emergency room, the emergency room can't find a bed for them and has to discharge them back to the streets, right to where the policeman's working, that's not a good solution. So I think we have some real work to do, but I think basic issues in insurance company attitudes towards mental health is fundamental.
There's a huge disparity in that. Yeah.
I do believe, though, that there is a major over-reliance on competency evaluations, because what happens is the judges don't feel they have alternatives because there is a lack of resources. So they use the competency system as a gateway into some treatment. And most judges sometimes don't understand the difference and think it is a treatment system. And those competency beds are gobbling up some of the civil commitment beds. And
Judge,
so,
I think that perfectly states what you said before of it's not necessarily treatment resistant, but the system is resistant, right?
And it's a 50-year-old model that just hasn't changed. We're using this competency system today that we used 50 years ago when there were very few people with mental illnesses in the criminal justice system at all. And so what should probably happen and what we do in Miami is we use competency very, very rarely. And instead we use diversion and get people treated, because competency, 70 to 80% of people in Florida who are quote unquote restored either have their charges dropped, they receive credit for time served, or they get probation and they leave the courthouse without any access to treatment. Now that's the definition of insanity. And so what we started doing is on misdemeanors, we don't even order psychological evaluations for competency anymore. We order an assessment for diversion. And even on felonies, we have an alternative program in Miami that if you are adjudicated incompetent on a felony and you cannot be restored in the community, we send you to an alternative program we designed that doesn't focus on restoring you, but focuses on reintegrating you back to the community. And once you're stable, we put you on our felony diversion program and we monitor you for another year and drop the charges. And it's just, to us, a much more sensible system. And it's about a third faster, 50% cheaper, and 100% better outcome. And so we just have to start rethinking, how to approach it. There's two great reports out there that I would commend people to. One is by the Council of State Governments Justice Center. It's called Justin Well. And the other is by the Conference of Chief Justices that came out just last year on competency. And it talks about different routes that we should be using for this population. In fact, the Massachusetts Chief Justice was on the Justin Well report and helped us with some of those recommendations. So
hopefully that's a step. So I want to ask you before, as what will be the last question about your vision, but real quick, I have a question from the audience. So the question is, does Vinfen have a program to train peers like Justin? And so we do. We hire, peers are an essential part of all of the programs that we have here at Vinfen. And in addition to having people trained as certified peer specialists, our directors of recovery oversee them, and we also train people as recovery coaches. So we do find that, peers are, I wanted to say something, Justin, when you were talking of, if you can see it, you can be it. And I see that all of the time, but if people see that they can be successful in their recovery through a peer, I think it really makes a huge difference. So what will be the final question, Judge, and we don't have a ton of time, but I wanted to ask you about your vision for the program, but could you also weave in something about maybe underserved populations like the LGBTQ plus or women's programs and how that looks with the vision of the program?
So thank you. And what's happened over the 21 years we've been doing this, we just, as I mentioned earlier, we've narrowed down these populations. And we've been enormously successful with 70 to 80% of the people that come into our program. But 20 to 30% are just too sick for what's available. And it's not a Miami problem, it's a national problem. There just isn't capacity for the most acutely ill. There's maybe a few state hospital beds, which really isn't the answer either, or there's a community mental health system or a crisis system, which really was never established to handle the most acutely ill either. And so what we're doing now is we're building this first of its kind one-stop shop facility that will be done in May or June of this year. And it's fortuitously and ironically, it's the old Competency Restoration Facility. So it's 180,000 square feet. And what it's going to be is a medical home. So it's going to have a receiving facility for both addiction and mental illness, a crisis stabilization unit, a short-term residential facility, a day activity program run by people with mental illnesses to teach self-sufficiency and recovery, a culinary supportive employment program to help people get job skills. There's a courtroom in the building so we can manage both their civil and criminal cases. It also will have a primary health clinic, a dental clinic, an eye clinic, a podiatry clinic, a living room model, trauma services, and it has 200 beds of housing right in the facility. And so the idea is to make sure that instead of just kicking people to the curb or prematurely discharging them from a hospital, that we gently reintegrate people back to the community with all the supports and services they need to maintain the recovery. And at the same time, it needs to be culturally sensitive. It needs to be sensitive to LBGT needs. We want to make sure trauma needs. We want to make sure that we are going to where the person is at the time and making sure that they get the level of care with the sensitivity that they need to recover. And that should be everyone's ultimate goal, just like it is with any other disease. And I think it's just really important that we start to rethink, how we deal with this problem. But, Dr. Hoffman and Patty are amazing examples of, working in a community and trying to improve it to make it so that we can all reach this critical mass and stop using the criminal system as the de facto mental health system.
And in serving those populations, we need to train staff to believe in recovery and that to know and understand their own implicit biases about special populations and to really be on board and not just check a box, because that's where a lot of programs are, my experience, and that, to really serve, we have to understand the needs of all these special populations.
I know you're running out of time, but one of the shocks that came up in our work was how much mental health issues there were among law enforcement officers. And about 20% of departments have severe PTSD. And we actually had to set up a program for our law enforcement to get treatment outside their departments because they wouldn't go for help. But to Justin's point, it has really helped make them much more empathetic to this population because they're suffering as well. And we've seen a significant turnaround and a kind of a cultural shift within the police department because of the services that we've been able to offer them and them realizing, hey, this affects everybody and everybody.
Thank you so much, Judge. So we actually have one more question, and that question is going to go to David and Patty. And that question is, we talked about public and private partnerships and taking care of in gaining resources. But who do you think is the most important advocate to get this sort of thing done?
I think it's a stakeholder, group. I think that, the partners need to come together. That was actually what was so successful when we initially launched our jail diversion program. It came about so organically because we had already been meeting. We had folks from many of the community service providers, BACO, Vinfen, the hospitals, the ambulance providers, the police, some city departments, all kind of talking, and sharing perspective on kind of what they were seeing in the community as needs. And then all of a sudden this funding stream came out. So I think it really requires that kind of collaboration, that cross-system, cross-discipline collaboration to advocate for a successful system.
Thank you. David, did you have anything? You got about 20 seconds.
No, I would agree. Unfortunately, this population needs other stakeholders to advocate for them a lot of the time. They're less able to advocate for themselves, unlike people with cancer and heart disease and other illnesses that have large advocacy groups. And so I think we have to get as many stakeholders together as possible.
Thank you so much. Thank you to all of the panel. I am so glad to be able to participate in the film festival again and be able to be in the presence of so many people that are making change in the world. So this concludes the second set of a film and live panel discussion. Thank you for joining us.
Thank you.
Thank you.
Thank you.